Okay, so I hope you all can see my screen. I will just make it full screen and then we'll start. Okay, so welcome to the 38th Journal Club. And today we are going to discuss a very important topic, and this is related to the headache. And we have one of the best faculties who does a lot of headache interventions, and two of our best speakers who are quite senior and have kindly consented to deliver the journal clubs today. So pain medicine in India is having diverse issues with variable standards and different learning requirements. As a result, there are different offerings with courses or programs ranging from a few hours, like 3 hours, to 3 years. So that's quite a big variability. And the time and money is quite a big factor when we talk about learning and understanding. So I think to overcome this issue, Mumbai Pain School was created as an initiative currently run by Panisha Spine Wellness and Pain Relief Center. And we are quite using the social media for dissemination of this knowledge. We have good presence on Facebook with lots of video views, on Instagram and Twitter also we have started recently. The courses, they are mostly online learning and on-demand videos. It is just like Netflix, and we are having both free and paid content. Most of our courses are, or content is free, but we have also come up with some paid courses. We have hands-on workshop. The next one is planned in October first week, and hope to see you all there. We are fortunate to have expert faculty from all over the world. It is said that the best teachers, they teach from the heart and not from the book. And a journal club is nothing but it's just a club. The only difference is we are going to discuss and critically evaluate recent academic literature, which is based on a defined subject, and we value the attendee participation a lot. And so there will be lots and lots of time for you to discuss, point out questions. Critical evaluation is encouraged. So this is the St. Bartholomew's Hospital, popularly known as the BARTS nowadays. And this was the venue for the first journal club by Sir James Paget. Across the Atlantic, Sir William Osler started the first journal club in that particular region. And the cost of the journals was what prompted him to do that. Even Tinsley Harrison had his journal club twice a month for critical evaluation of recent academic literature. So we'll stick to the timelines. So I request both the presenters to stick to the timeline. Healthy skepticism or praise is most welcome. So please feel free to reach out to us after the talk as well as during it. Just raise your hands, we'll unmute you and we will go on with the sessions and your question and answers. So this is a bit about me, but today we are happy to have with us Dr. Ashu Jain. He is head of Department of Pain Medicine and Palliative Care at the Artemis Hospital in Gurugram, that is Delhi NCR. He is an experienced faculty across national and international conferences. He's the examiner for FIAPM, which is the program from the Indian Society for Study of Pain. He's also the program director of FIPM. We welcome you, sir.
Thank you, Sidharth. Thank you so much.
Great. So now over to Dr. Aanchal for the first presentation. And I will stop sharing my screen. Dr. Aanchal, if you could put up your CV slide so that I can just introduce you and then you can begin. Yes, so I can see your slide. You can make it full screen now.
Do you see it?
Yes. So Dr. Aanchal is MD Anesthesia from PGI Chandigarh, one of the premier institutions in the country. She's done her fellowship in pain medicine from Chicago in United States. She's board certified from American Board of Pain Medicine. Currently, she's working as a consultant pain and palliative care, Venkateshwar Hospital, Dwarka, New Delhi, and also New Life Multi-Speciality Hospital, Gurugram, Haryana. So over to you, Dr. Aanchal.
Thank you, Dr. Sidharth. So today we are here to discuss about this paper, which is the title of which is the efficacy of Sphenopalatine Ganglion block and radiofrequency denervation in the treatment of cluster headache. And it's a case series which was done by Amigi et al. From the Department of Anesthesiology and Critical Care in Pain Medicine in Tehran, Iran. This paper was published in Anesthesia of Pain Medicine in 2020 December month. So introduction, the cluster headache is one of the most common cephalgias, and it's a variant of primary neurovascular headaches, and it's characterized by unilateral, recurrent, and short-lived pain episode that also has symptoms of autonomic dysfunction. With no treatment, pain usually lasts for 15 to 180 minutes. And usually the first line of treatment is medical management, which is focused on first the abortion of the current acute attack and then prophylaxis for the future headaches. Patients who are refractory to medical management, they might benefit from the interventional management. So Sphenopalatine ganglion is the largest extracranial neural structure, which is located in pterygopalatine fossa. This has sensory, motor, and autonomic neurons, and it plays an important role in pathophysiology of cluster headaches. So Sphenopalatine ganglion block and radiofrequency has already been proposed for treatment of cluster headaches, and is standard of treatment for a headache in the pain literature. But they say that the only few studies have evaluated the extent and the duration of the efficacy of this intervention. So the objective of this investigation was to evaluate the efficacy, duration of pain relief, and complications, if any, of the Sphenopalatine ganglion block and conventional RF in the treatment of cluster headache. So a patient who with cluster headache who received medical therapy, which included acetaminophen, NSAIDs, and oxygen for at least 6 months. But the patient who were either resistant or intolerant to this treatment was referred to the pain clinic by neurology department. And this was conducted between 2014 to 2018. So when they came to the pain clinic, the criteria to recruit them for Sphenopalatine ganglion block and then denervation was age between 70 to 75 years old, all patients with cluster headache who met the International Classification of Headache Disorders criteria, and patients who were intolerant or had an inadequate response to medical therapy for at least 3 months, and patients who were willing to participate in the interventional management. The patient who had any coagulopathy or any infection or lesion in the path of needle insertion or pregnant patients were excluded from the study. So this treatment had 2 parts. First, they did a prognostic block, and then subsequently, if patient had good relief, they followed it by the RF denervation. So during the procedure, standard ASA monitoring was done, which included ECG, SpO2, heart rate, respiration, NIBP, and they used a 22-gauge spinal needle. Before the procedure, they gave sedation with 1 milligram of midazolam and 50 mics fentanyl. And then they raised the skin wheel by local anesthesia of 0.5. This is 10 ml of 0.5 lidocaine. So this is a procedure. The needle was placed over supramandibular notch, and then it was directed towards the sphenopalatine fossa by directing it little cephalad and medial. And once the needle tip was in correct position as confirmed by fluoroscopy, as we can see in the fluoroscopy, this is the final position of the needle. In the lateral view, you can see the pterygopalatine fossa as inverted bass appearance going through the mandibular notch. And this is the AP view. We would start once you would stop once your needle reaches this lateral nasal wall. And once the position was in the final place, the prognostic block was given by just 2 ml of solution, which consisted of 4 milligram of Dexa and 1% of lidocaine. I just took few pictures. These are just the Google pictures, just to elaborate a little bit about the procedure. This is just a bony view. If you would see, this is the supramandibular notch. You would go from there, and this is a pterygomaxillary fissure. You could hit lateral palatine bone, but then you would direct your needle to the cephalad. And this is exactly the lateral view. How you would see it once your mandible is too lateral, like your mandibles would be clearly aligned. And this is just the pictorial representation how your needle will directly go. And this is how it will look under fluoroscopy. So after the prognostic block, they did a follow-up visit 2 days after the block, and how they evaluated the clinical response. It was by the pain inventory, brief pain inventory. It's basically a multi-dimensional questionnaire which has 4 numeric rating scales to measure pain intensity, which is when you report your least pain, your worst pain, your average pain, and your current severity, like at present when you are when you encounter the patient. Also, it has some questions about the pain relief and interference with functional enjoyment and the mood. So if the patient had at least 50% of the pain reduction within the first 5 hours after the injection, they were scheduled for the therapeutic block, which was RF denervation. And this RF denervation was scheduled 1 week later. So for RF procedure, they used a needle which was 100 mm with the active tip of 5 mm. It was 22 gauge and it was a curved needle. RF device was Neurotherm NT 2000 IX. So after the needle was in final position, the same procedure as we just discussed, the sensory stimulation was initiated at 50 Hertz, and then it was gradually increased to 0.5 volts. And once you had sensation of tingling in the nasal root, this was considered a satisfactory response. And consequently, the tip of the needle was in right place, adjacent to Sphenopalatine Ganglion, far from maxillary or palatine nerves. So after getting the acceptable sensory stimulation, they injected 1 ml of 1% lidocaine. And subsequently, the conventional RF denervation was done, which is temperature of 80 degrees. They used it for 90 seconds, 2 cycles at 1 point, and they did 2 close points. So follow-up visit evaluation was also done with the BPI questionnaire, and it was done at 48 hours, and then subsequently 1, 3, and 6 months after the RF. So they were the patient who were found to be eligible to be enrolled to the study was 23. Out of these 23 patients, 4 declined the interventional treatment, so they were excluded. So finally, they did the prognostic block in 19, out of which 4 patients did not respond to this block. So out of 19, the 4 patients were excluded, and finally 15 were selected for denervation. Out of these 15, 4 declined the denervation, and then 11 finally consented for RF, and then it was performed on 11 patients. So these are just the basic characteristic of the patient who participated in RF. So all of them were 46 years of average age, male female ratio were same, and almost the pain intensity were also similar. So out of these 19 patients, 15 had acceptable response to prognostic block, which we consider as 50% of more than 50% of pain reduction, and 11 out of these 19 patients had 100% pain reduction after the procedure. So 15 patients who got the good response, out of these 11 got 100% response. And we know that 4 patients did not get the adequate relief. So main pain reduction of the prognostic block was 75%. And this is the chart which shows the pain relief after the RF denervation. So you can see that mean pain intensity was initially 8, and it reduced to 2 after 48 hours, which is 75% of the block. This is after the prognostic block, and this is 48 hours after the RF. And this is the pain intensity reduced to 1.8, so 77%. So this decreased to 59 after 1 month, and then 50 after 3 months, and 31% of pain relief after 6 months. So pain intensity was kind of increased at the end of 6 months. So they found 2 complications after the RF procedure. One patient had soft tissue infection, which was successfully treated by antibiotics. And second patient had sensory deficit over the maxillary dermatome, and then which lasted for 1 year. They didn't mention the treatment. I think they managed it just conservatively. So discussion, some patients with cluster type cephalgias develop a chronic and drug-resistant headache, which is usually not responsive to conventional treatment. This study found that the pain intensity decreased by 50% or more at least till 3 months. And even after the 6 months follow-up, pain intensity was decreased by 31%. They have other similar studies as well, which have found that the efficacy of the SPG denervation in addition to the evaluation of simple blocks, and they also showed that the grade of recommendation for RF procedure was grade B. Then the Naruzzi et al. Also found this treatment is highly effective for chronic cluster headache, and they figured out that the pain disability index was till 12 months post procedure. If they found improvement in that, and also the decrease in the mean attack intensity till 18 months. Another author, Sanders et al., also found similar results, and they evaluated up to 70 months, and they found good results up to that time. So side effects which have been reported in other studies are also mostly temporary, which includes infections, epistaxis, hematoma, anesthesia, and hyposthesia in palliative pharynx. So limitation as accepted by the authors are, they did not report the change of patients' analgesics after our interventions, that whatever they were taking before, whether the pain relief was along with those analgesics or without those. And also their patient did not be representative of the general population, since they were just coming to the neurology group and not presenting to them directly. So I figured that this study kind of further strengthens the evidence of the sphenopalatine ganglion RF and the block in cluster headache patients. But in this technique, there was little clutch that I did not see any contrast injection, many mention of contrast injection to rule out the intravascular check. So because that area is highly vascular, and also there is a little medical therapy given before intervention. They just use acetaminophen, NSAIDs, and oxygen therapy. There is no mention of any neuropathic drugs, which is used for prophylaxis or abortion of the attack. So take-home message is sphenopalatine ganglion conventional radiofrequency denervation can effectively decrease the pain intensity of the cluster headache with acceptable side effects for at least several months, which is 6 to 18 months if we combine many steps. Thank you.
Thank you, Dr. Aanchal. And now over to you, Dr. Ashu. Do you want to ask questions now, or will we discuss in the end together?
I think after the second presentation.
Okay. So I think we'll move on to the second presenter. Dr. Sanjog, you can start sharing your screen and put up your CV slide so that I can introduce you. And then you can begin. Yes. So Dr. Sanjog Mekewar is DA, DNB, and FIPM. He is a consultant spine and pain physician in Sahyadri Hospital, Sainath Hospital, and City Hospital in Pune. He's also a visiting consultant at BJ Medical College and Sassoon Hospital, Pune, and is also the director of Jivisha Pain Management Center, Pune. So his area of interest is spine endoscopy and regenerative medicine. He's got many publications in national journals. He likes to travel and explore. So welcome, Dr. Sanjog, and over to you for today's talk.
Thank you. Thank you. Good evening, everyone. The article that I'm going to discuss today is a case series, and it is titled as Sphenopalatine Ganglion Block for Refractory COVID-19 Headache, a descriptive case series. It was published in a Brazilian Journal of Anesthesiology in April 2021, and the authors were Felipe Machado et al. From Sao Paulo, Brazil. So we all know that the predominant symptom of COVID-19 infection are the respiratory symptoms. However, the neurological symptoms are also reported in up to 36% of the COVID-19 patients. And these neurological symptoms include headaches, impaired consciousness, ataxia, acute cerebrovascular disease, seizures, hyposmia, hypogeusia, and neuralgias. If we consider the headache alone, then it is reported to be present, or the incidence is about 6.5% to 34% of all the COVID-19 patients. Now, the mechanisms that are likely explained which lead to these headaches in the COVID-19 patients is the systemic illness rather than the primary invasion of the central nervous system by the virus. And a number of medications they have been tried for treatment of these headaches, which includes the anticonvulsants, calcitonin gene-related peptides, monoclonal antibodies, somatriptan, and non-steroidal anti-inflammatory drugs. However, these drugs, the action of these drugs is, it has been observed, it is very limited. Now, sphenopalatine ganglion has multiple autonomic and somatic neural connections to the head, neck, and shoulder, and it has been used in the treatment of various primary headaches. So this case series presents 6 COVID-19 patients in which intranasal bedside sphenopalatine ganglion block was performed with a cotton tip applicator and 2% viscous lidocaine to treat this post-COVID refractory headache. Now we'll go to the cases now. The first case was a 28-year-old female with no previous comorbidities, admitted with COVID-19 respiratory symptoms, holocranial pulsatile headache, and anosmia, with no other neurological symptoms. The headache was refractory to amitriptyline 25 mg per day, metimazole 6 grams, pericoxib 80 mg, and sumatriptan 25 mg. However, after sphenopalatine ganglion block, there was immediate headache resolution with no recurrence in the next 2 days. The second case was a 45-year-old female with a history of hypertrophic cardiomyopathy and depression, and she was already taking atenolol 75 mg per day and desvenlafaxine 50 mg per day. She was admitted a few weeks after the resolution of COVID-19 respiratory symptoms with a sole complaint of holocranial pulsatile headache. The CT scan was done, it was normal, and there were no other neurological symptoms. The headache was refractory to desvenlafaxine. She was already taking then acetaminophen 3 grams per day, ketoprofen 200 milligrams per day, and sumatriptan 50 milligrams. After giving the sphenopalatine ganglion block, there was a significant reduction in the pain score from severe to mild pain, which was resolved in the next 2 days with the same analgesic regime and did not relapse. The case 3 was a 46-year-old female with no previous comorbidities. She was admitted with COVID-19 presenting mild respiratory symptoms, asthenia, nausea, vomiting, anosmia, and holocranial pulsatile headache with no other neurological symptoms. Now, the pain was refractory to metimazole 4 grams per day, codeine 40 milligrams per day, amitriptyline 75 milligrams, and acetaminophen. Now, the SGB was performed with a significant reduction in the pain score from severe to mild pain, which was again resolved in the next 2 days with the same analgesic regime. The case 4 was a 36-year-old female with no previous comorbidities, admitted with dyspnea, nausea, coughing, dorsal pain, and holocranial pulsatile headache, and no other neurological symptoms. Again, she was refractory to the medications. After SGB, the patient reported a 50% improvement in the pain symptoms. SGB was performed again with the same technique, after which the patient reported complete headache resolution with no recurrence in the next 2 days. Case 5 was a 36-year-old female with a previous history of migraine, for which she was prophylactically taking amitriptyline 25 milligrams per day. After COVID-19 diagnosis, the patient was admitted with respiratory symptoms, anosmia, and headache. The headache was described as pulsatile and similar to the previous migraine episodes. However, the usual episodes were unilateral, and the current episode was holocranial. So headache was again refractory to the medications. After SGB, the patient reported complete headache resolution with no recurrence until discharge. And the last case was again a 41-year-old female with a previous history of obesity and DVT in the right popliteal vein. She was admitted with COVID-19 and experiencing dyspnea and headache. Respiratory symptoms resolved rapidly, while the headache was refractory to all the medications. In the clinical examination, the patient had signs of occipital neuralgia also, as well as non-specific holocranial pulsatile headache. So SGB was coupled with the bilateral occipital, greater and lesser occipital nerve blocks, and they were performed successfully. There was an immediate resolution of headache with no recurrence in the next 3 days. So we look at the summary of all these cases. Initial headache severity in all these cases was severe, and all of them presented with a holocranial type of pulsatile headache, except the last patient, which also had a component of occipital neuralgia. Out of the 6 patients, 2 patients received triptans in the initial management of these headaches, while the rest of them received the other medications. Now, the number of blockades necessary for pain control, in 4 of them, the pain was resolved with only single injection, while one of the patient required 2 SGB blocks for complete resolution. While the last patient, he received along with the Sphenopalatine Ganglion block, she received the bilateral occipital, greater and lesser occipital nerve blocks. Now, the headache severity after blocks, there was no pain, or there was complete resolution of pain in 4 of the patients, while in 2 patients the pain decreased from severe intensity to a milder form, and there was no recurrence of pain after the blockade. Now, in discussion, there was significant variability in the initial headache treatments between the 6 presented cases. So we have seen everybody received different kind of medications and different doses of the same medications. So this variation was explained by the fact that the different patients were treated by non-specialist physicians from different medical teams before the pain staff consultation was done, resulting in different prescriptions. Now, the Sphenopalatine Ganglion block was indicated only to patients experiencing a headache refractory to treatment, considered by the neurology staff as a lack of response to at least 3 analgesics with different mechanisms of action. Now, the side effects which were seen in these patients, no patient had any epistaxis, hematoma, lacrimation, or signs of infection. However, anosmia and hyposthesia of the nose, root, pharynx, and palate were present in all the 6 cases. These effects were transient and reversed in few hours. Now, the postulated mechanism of action of this SGB block in the treatment of the headache, there were 3 mechanisms which were postulated. First was the reduction of autonomic stimuli to the head, neck, and shoulder, which can explain its effects on pain with an autonomic mediated component. Then second mechanism that was postulated was the mild intracranial vasoconstriction that this SGB block causes. And third was the reduction of local release of vasoactive substances in the pterygopalatine fossa, including calcitonin gene-related peptide. Now, the limitations accepted by the authors is first that this series was observational retrospective design. There was non-standardized analgesic protocols, and it was a very small sample size, only 6 patients were included. So in critical analysis, according to me, this has a very low level of evidence. It is a case series, and all the patients who were included in this case series were all females. There were no males included. Then there was no standardization in this case series, and there was poor description of methodology. So there was no inclusion exclusion criteria and the methodology, how much drug was given. So there was very poor description of methodology. And the follow-up which was done was only for 2 to 3 days, which have been shown in this study. So after 2-3 days, what was the pain response, pain recurred? So we don't know about that. So these were the 4 points that I think was important. Now, the take-home message is that in post-COVID patients not responding to conventional treatment of headaches can be given a trial of SPG block. However, more robust studies are required to actually contribute to the evidence of this case series. Thank you.
Great. Thank you, Dr. Sanjog. And now we'll go on to the quick Q&A session. And Dr. Ashu, over to you now.
So actually, after going through Aanchal's presentation, I was about to talk about this, what the second presentation was. So I'll tell you my personal experience. I was called in the evening, late evening, to a very high profile person's house who was about to go to BRIC with Modi ji, BRICS meeting to Brazil. And he was having a severe headache, this kind of headache, red eye and everything. And a whole battery of 10 people treating him. Now, my CEO asked me to do some blocks. So person who is traveling 3 a.m. with Modi, how can I do this? So this is what I exactly did. Taking a 2 swab with lignocaine, putting into the nose, and 10 people standing in his house. Within 20 minutes, there was no headache, no injection. The eye was absolutely normal. Now, everybody looks like fool, ke bloody jokers, but you are treating. You know, so this is the power of intervention. And that was my first experience with intranasal placement of lignocaine swab in these patients. And I was really amazed. Kitab mein padha tha, but that was my first clinical experience, and that was in beginning of my career after joining Artemis. So then I have done this in few patients who came to our clinic with intractable headache, and take my word, to abort this acute attack, this is the simplest thing that anyone can do. जिसके पास थोड़ी भी anesthesia की training है, they can take a what I took those throat swab from microbiology lab. हाँ, दो swab लिया, उसको dip किया, middle truncal से पीछे डाला, 10 मिनट के लिए भूल गया. And after around 15-20 minutes, headache was gone, and this is a very good handy treatment. And the beauty is anybody can do. And I think all our anesthetists, they are able to do this. And this about that acute attack. बात की बात है, but you know that thing is gone when person is suffering from 2, 3, 4, 5 days. So I agree with this technique, and yes, it should be practiced. Now that was for this intranasal technique. Now coming to Sphenopalatine, I would say this is not a technique which is very handy and needs a lot of expertise. And this is one technique where we go out of plane. You will agree. We don't go by tunnel vision, and it becomes difficult to differentiate between the maxillary nerve and the ganglion per se. And if you are really wanting result, and as Dr. Aanchal was mentioning that one patient has this maxillary nerve associated hypoesthesia and all this is bound to happen, because it is sometimes very difficult to place your needle exactly on the ganglion. So it's a very challenging procedure, and all of will agree that it is not possible always to do Sphenopalatine RFA. Block is still okay because we have to just deposit the drug, but doing RFA, and that too without involving maxillary nerve, is a difficult task. And I'll share one of my experience. Patient was referred to us from Jammu, Dr. Sidharth from your city, and Rohit Bhai sent the patient to me, and we beautifully did this RFA. But when I took that sheet out, that sheet on the face, I was shocked to see big black eye, and she was a beautiful Kashmiri lady of 27 years, and you can think the pain and agony I have gone through after seeing the huge black eye, and I don't see anything here. So probably I have hit while I was going to the front from entering from this point, I have hit some artery or facial artery branch, and it was a big hematoma involving the eye. So my advice will be, it has to be come with some experience and rate of complication. This is one. And second most important point is, see, what we call it as cluster headache or frontal headache, many of the time the loop is from C to C3. We are forgetting about that very important loop. And we have learned in our practice, and take my words, in last 2 years, I have not done even single Sphenopalatine. Either I used to jump and do all Sphenopalatine in frontal headache. All patient has responded very well to C2, C3 block and proceedingly RFA. Again, I'll tell you a very, very high profile patient, CEO of very big company, came to us, 20 years of cluster headache treatment being taken from Medicity, admitted in the hospital. I told her, Madam, I C2, C3 block dunga, followed by RFA. She said, do RFA. I did C2, C3 RFA 9 months back. The 20 years cluster headache has gone. 9 months down the line, there is no headache attack, nothing. So I think if we go through this, the afferent loop of this cluster headache, trigeminal nerve is involved somewhere, because without that afferent loop is not completed. And C2, C3, as you all know, is the fiber, they are intermingling with trigeminal spinous nucleus. So that is a very important loop, and we should always and try to do C2, C3 block in this patient with very good results. And I will find that C2, C3 is much easier than doing Sphenopalatine. So this is my take over this kind of headaches.
Great, sir. So we have a question from the audience also. I knew about your first experience also. I think you shared with me quite early.
Yes.
And that's why whenever I think of Sphenopalatine, I think of you. And also there are some other physicians also whom I think of in SPG, but definitely one of the foremost are you. So now we'll take one question from the audience. So we have a comment on Facebook, who I think this is about Dr. Aanchal's paper, Dr. Sanjog's paper, and they have said that the follow-up is only 2 days, but that's okay because you're just going to do a block. It is a block. Even 2 days is more. I mean, you can after few hours.
No, Siddharth, it is not matter of days. It is a matter of aborting an acute attack.
Yes.
As simple as that. So once you abort this acute attack in cluster headache, you don't know when the next attack will come. It may not come for 3 months. It may not come for 6 months. So we should look at it in that perspective, not for number of days. Once you have aborted the attack, another thing I'll tell you, if you can't do anything, give 60 milligram of prednisolone, 2 doses. This will be aborted. So these are small tricks. I have told many my colleagues, you give a high dose of 2 doses of prednisolone, the headache will be aborted. So these are the things for aborting the acute attack. We are not going into days of this thing.
Yes. So that is what the purpose was also there in that.
It's a COVID-related headache and cluster headache. So we don't
I
know
think
the
Sanjog presented the holocranial
COVID-related
pulsatile headache after the COVID-19, not the so that may be relevant because that person is suffering from days, not like an episodic one. Right? So that the long-term follow, at least a week or 10 days follow-up would be relevant, I think. Because the headaches we presented were different, I think.
Yeah. The presentation was quite different. Yes. Okay. So we go to another question, which is okay, this is already answered. Dr. Sudhakaran is asking about clinical experience of nasal approach versus classical approach for prognostic Sphenopalatine block. So, sir, will you do ever nasal, diagnostic Sphenopalatine?
I think that makes sense.
No. Sorry, the nasal approach versus the classical approach means how you do the RF through the notch and everything. Will you do that once your nasal block is positive? Will you do again that and then again the RF?
That means if your nasal block is positive, you will go for RF in next sitting. No point in doing diagnostic block of Sphenopalatine again. Yes,
because the diagnosis is already made, and I think no, there's no reason to do that again.
Because once you are putting intranasal swab, it is only Sphenopalatine ganglion which is getting numb. So there is no point of doing a prognostic or diagnostic block to the same area. And actually, I have done many patients like this. When you do intranasal first and patient is happy, next time we will plan patient for straight away for this RF.
Great. Dr. Aanchal, Dr. Sanjog, any other question? The attendees, if you want to ask any questions, you are not most welcome to ask now, or you can raise your hands. I can unmute you. You can also speak.
Up to sir, Ashu sir, do you do this Sphenopalatine denervation for atypical facial pain? Or
yes, many times. Burning tongue syndrome, unilateral facial headache where you facial pain where atypical, you don't have any explanation. So we'll try blocking Sphenopalatine and see. That is a standard protocol. I have treated a very good number of burning tongue syndrome or burning mouth syndrome with the Sphenopalatine. It responds. It is what trying block followed by, if the block is positive, then followed by RF.
So I had one patient who, it was referred to me from a MDS, and according to them, she had a trigeminal neuralgia type of presentation. And what they did was they gave the peripheral injections, posterior alveolar and mental and all those things. Now, the pain got relieved somewhat for 1 year, but it recurred, and now the pain was in the center of the palate, hard palate. So actually, and it was not like electric shock like, or it was a continuous type of pain. So in this, I did this Sphenopalatine, and the patient got relief. So
Actually, you need to understand the connections. If you have seen our one presentation which we made on Sphenopalatine, so it is quite complex connection that is just based on the anatomy. We are not taking the variations into the account. And if you see, is the end point just before the end organs. This is this ganglion. So I think a diagnostic thing can also not 100% tell you whether the RF can work or not. So keep your prognosis always guarded. Sir, has it ever happened diagnostic positive but RF failed with you?
No. Yes, the amount of pain relief may vary from 50 to 100%, but absolute failure is never reported.
Yes. So
But
with
this
me,
is true
what has
that
happened is
sometimes the degree of pain relief may vary patient to patient.
So with me, what has happened is that we did a patient. I think Dr. Sanjog was also there that time. So what we did was we did repeated, nasal Sphenopalatine. We used to call her in OPD after say 2-3 days, and whenever we used to give her a nasal one, and then we posted her for this RF, and she had relief for a few months, and then she came again, for the similar pain. So now we are evaluating few months, I think 1.5 years probably. And then she's come again. Now we are evaluating again whether to repeat the procedure or not. So that is quite.
So that can happen that patient duration of pain relief can be 1 year, 2 year, 3 year maybe.
But
yes,
we are very cautious for the next intervention. First intervention, we are just
C for
cautious.
C2, C3 in this patient this time.
Yes.
Try
Maybe
to explore
yes,
C2,
we
C3.
can explore that, and now it's with the ultrasound. It's we can easily do a diagnostic, and then later on, if it's positive, go with the fluoro RF, and that would be great. Okay, so we have another question. After that, we'll end the session. So, if the SPG block is successful with 50% pain relief, what should be the next step? C2, C3, or SPG or RF? So Dr. Akhil, you are confusing both things. So if you are proceed on only one line, don't do 2-3 diagnostics, then you will not know only. So we call it a with the name of a specific doctor. So we don't do multiple procedures in the same patient, because then we don't know what has actually worked. फिर आप RF किसका करोगे? Then you do multiple RFs also, but that is not justified.
No. You have to be following a single pathway. So you decide one and follow that.
Yes, very important. So if you are not doing that, then you are not knowing. You are just hitting in the dark. Then it is just like when some patient comes and tells me, "Sir, हमको full body MRI. Get a full body MRI done." So that is not the way to do it.
I answer these patients. You don't need full body. You need a contrast MRI of brain only. So वो पूछते हैं क्यों? बोला वो कीड़ा देखना जो तेरे दिमाग में घूम रहा है. So I have answered many times this thing to patient, and they get their answer. Always, this is my standard thing. Whole body MRI कराना नहीं, दिमाग का करा, उसका वो कीड़ा देखना जो घूम रहा है.
Great. So let's move to another question. This is for, okay, somebody is asking, Dr. Sudhakaran is asking, this C2, C3 RF for attack or for chronic migraine, means for prophylaxis, for termination of the attack, or for long term?
See, both. If your patient is in acute pain, you do diagnostic C2, C3, patient get relief. Now, if the patient is in your follow-up, can come back, wait for the next attack to come. Then I'll tell you, I have at least 30-40% patient in my clinic where we did diagnostic. They never required RF because we have broken the vicious cycle of pain, and the block itself will relieve 30-40% of patient. No need of jumping to RF in first go. Like we have 50% international patient, so we'll do RF without mugging up our brain because they will have to go back to their country. But otherwise, in Indian patient, we will always do a block and wait for the next time the pain to come, and only go for RFA if pain comes, and 30-40% will be permanently relieved with block.
Yes, of course. That will be that's what we do as well. So
yes,
we try
no
to
need
break
to
the
jump
cycle
for RF as such.
So what is in comparison to C2, C3 and greater occipital nerve? So
no, we don't do greater occipital. You have to hit C2, C3. हम वो उसमें विश्वास नहीं रखते.
So I think quite valuable insights there. And in fact, if you brush up the literature, you'll find a lot of mechanism. Now there is mechanism by, I think it was by Dr. Naruz et al. Only, that the intranasal mechanism is not very clear. And how it.
No, I'll tell you what. Trigeminal is the afferent limb. Sympathetic system is the efferent limb.
Yes.
Okay,
yes.
so the mechanism is different. So this is what I was exactly trying to say that you do C2, C3, you are blocking the afferent limb. And I think blocking afferent limb gives you better result for a longer duration, because you are you are blocking the afferent pathway, so the headache is not triggered at all. And
Yes.
doing sympathectomy is efferent limb. So it is cause and effect. You are treating effect, treat the cause. So,
and if I add the neuromodulation, it also does, it is even after that, the third one, you are even modifying the
this one,
yes,
deep
correct.
brain stimulation. So
Yes. So whatever you are
lot
doing,
of neurologist friends, neurosurgeon friend are our enemy. We tell them no need to do your fancy things. We will abort this attack with our.
yes. So that is what you need to understand, that go by stepwise
You
fashion.
need to understand the pathophysiology of the headache.
Yes, and move stepwise.
Yes.
Great. So hopefully we'll have a, I don't know when I can get the good faculties lined up, but we'll have a good headache webinar very soon. Okay, so thank you all for your time, and let's move on to the last portion, and I will just end the session now. First of all, special thanks to Dr. Ashu and for sparing your valuable time, and also to both the speakers, Dr. Sanjog and Dr. Aanchal. So guys, the secret of getting things done is to act. So just join our mailing list. We also have a WhatsApp group. The link is in chat or in email. And your suggestions and comments are most welcome. Please write anything, whatever you want, whatever is in your mind, please write to us, and we'll be happy to try, implement, give positive feedback, negative criticism. Everything is most welcome. Just write on mumbaiPainSchool@gmail.com. And with these words, until next week, have a good time. And those of you who are watching from India, and especially for today, Ganesh Chaturthi greetings. Thank you.
Yeah, from my side also. Happy Ganesh Chaturthi. Thank you. Bye.
Thank you.